From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, I'm Dr. Kristin Walter, Senior Editor at JAMA. I'm joined today by Dr. Sadiya Khan, who is the Magerstadt Professor of Cardiovascular Epidemiology and an Associate Professor of Medicine at Northwestern University's Feinberg School of Medicine here in Chicago. We will be discussing a study that was published in the December 5th issue of JAMA titled Cardiovascular Health in the Postpartum Period. Welcome, Dr. Khan.
Thank you so much for having me.
So to start off with, can you briefly discuss recent U.S. maternal mortality rates and which groups of people are most affected?
This is a really critical public health issue today. We know that in 2021, over 1,200 pregnant people died during pregnancy or within 42 days of delivery. And that's a significant increase from the two preceding years in 2020 and 2019. We also know that there are significant racial and ethnic disparities with 2 to 3-fold higher rates among disadvantaged individuals, specifically those who identify as non-Hispanic Black, American Indian, Alaskan Native as well.
So as you mentioned, these maternal deaths can occur both during and after pregnancy. Can you describe when these deaths typically occur in relationship to pregnancy and how many of these deaths are considered preventable?
Yeah, that's a really important point because we know that almost 80% of these deaths are preventable and more than half of them occur after delivery at a time when many people may no longer be in care or receiving care and may have thought that the risks associated with pregnancy are gone because they're no longer pregnant.
And what do we know about the prevalence of poor cardiovascular health among individuals in the U.S. prior to pregnancy?
This has really become a growing problem and one where we've started to pay more and more attention. We know that rates of obesity, pre-pregnancy hypertension, pre-pregnancy diabetes are all increasing. And our best estimates suggest that less than half of individuals entering pregnancy have optimal cardiovascular or heart health, specifically related to some of these risk factors that put them at higher risk, not just for heart disease like we traditionally think about, but also for complications related to pregnancy and in the postpartum period.
And can you outline which 4 conditions are considered adverse pregnancy outcomes?
Many complications can occur during pregnancy, so it's important to define what we're talking about specifically related to adverse pregnancy outcomes. And these are specifically defined as hypertensive disorders of pregnancy, new onset elevated blood pressure during pregnancy, gestational diabetes, which is new onset insulin resistance during pregnancy, preterm birth before 37 weeks gestational age, and a small for gestational age infant.
And how common are adverse pregnancy outcomes, and what is their association with the lifetime risk of cardiovascular disease?
Our best estimates suggest that these complicate at least 1 in 5 live births in the United States. And if we think about individuals having more than one pregnancy in their lifetime, we're actually probably looking at a lifetime occurrence of more than 20% for each birthing adult. Over the past decade, we also have generated a lot of epidemiologic evidence that suggests that individuals who have adverse pregnancy outcomes, so the ones we just discussed, have a much higher lifetime risk of cardiovascular disease. So following a hypertensive disorder of pregnancy or gestational diabetes, we know that people are at much higher risk of developing hypertension, diabetes, and heart disease in the next 10 to 20 years.
And can you describe what Life's Essential 8 is and how it can be used to assess for cardiovascular health in the postpartum period?
Life's Essential 8 is a really helpful framework that was defined by the American Heart Association. Originally in 2010, they identified 7 factors and called them the Life's Simple 7. These included diet, physical activity, tobacco, body mass index, blood pressure, cholesterol, and glucose levels. And then recently, last year, they added sleep duration and quality to come up with the Life's Essential 8 as a way to assess and really intervene on cardiovascular health as a composite so that we're not just dealing in isolation with blood pressure or obesity, but the fact that all of these work together and are interrelated to optimize health.
And during that first postpartum year, what are some lifestyle improvements that can be used to promote cardiovascular health?
It's a really important time because a lot is changing. So, that first year postpartum, there are many important targets where we can really make a difference on improving cardiovascular health, not just during that year, but really for the life course for that individual, and hopefully also across generations, as these changes could help improve overall heart health for children and throughout their life course. One of the things that can be really important during this postpartum year is return to pre-pregnancy weight. We know that pregnancy weight gain, even when appropriate, can be an important risk factor for obesity if people do not return to their pre-pregnancy weight during that first year. In addition, support for lactation and breastfeeding can be really helpful to improve metabolic health and cardiovascular risk factors during that year.
And are there any dietary or physical activity recommendations that are recommended?
That's a really important point as well to think about lifestyle interventions. There are almost no restrictions on physical activity during pregnancy. And if optimal physical activity is maintained during pregnancy, that can be continued postpartum. However, even initiating postpartum physical activity can be a really important factor in improving cardiovascular health overall and also achieving that goal of returning to pre-pregnancy weight. Promoting a healthy diet is also really important and can be very helpful, especially dietary patterns like the Mediterranean diet, which have been shown to lower cardiovascular disease risk.
And I'm assuming smoking cessation is top on the list as well.
Absolutely.
Now, ideally, all postpartum individuals would receive counseling on cardiovascular health at their postpartum visits. Currently, what percentage of postpartum individuals report receiving this counseling at postpartum visits?
The postpartum visit is really an ideal opportunity to integrate counseling specifically related to healthy eating, exercise, and losing the weight gain during pregnancy. But recent data demonstrated that only approximately 60% of individuals reported receiving this counseling, and that was even if they had cardiovascular disease risk factors coming into pregnancy, like diabetes or hypertension, or developed an adverse pregnancy outcome during the pregnancy.
And why do you think that is, that those rates are so low?
I think it's important to think about whether or not the rates are that low or the retention of that information is that low, maybe one critical question. But part of it is the challenge in these visits when so much is trying to be covered during the postpartum visit that perhaps this isn't ranked as important or as highly. Perhaps for individuals themselves, that counseling may be provided but not retained. So it really speaks to the idea that we need to think of disruptive or innovative solutions that work within the health system and outside the health system to help prioritize and implement this type of counseling.
Yeah, and your article does outline some ways to improve cardiovascular health counseling throughout the peripartum period. Can you describe how the extension of postpartum Medicaid benefits to first-year postpartum could be helpful?
One of the critical things in being able to receive this counseling is to be present for that postpartum visit and also to have the opportunity to return to care following that. Specifically, we know that individuals who have hypertensive disorders of pregnancy need to have continued blood pressure monitoring following the pregnancy. However, if someone doesn't have access to care, they may not be able to return to have their blood pressure monitored, to have initiation or titration of therapies as needed. So Medicaid extension can be a really critical piece from a policy level to help ensure that people have appropriate access. Now, we know that alone is probably insufficient, but it has to be a critical first step.
And what are some other potential solutions to improve the cardiovascular health counseling that could be applied both on the individual level or within the community or in health systems?
I think we all are trying to think of the most creative solutions that may be possible and think about ways at the individual level and at broader community and health system levels. At the individual level, there are some exciting technologies, particularly with wearables and digital health apps, that may help modify as well as motivate individuals in unique ways to be able to adhere to some of these cardiovascular health behavior interventions that we spoke about. Telehealth has really expanded since the pandemic, and that seems like a great opportunity, particularly for birthing adults who may be very busy with childcare responsibilities. We often hear that one of the critical barriers in coming back and having follow up after pregnancy is the lack of childcare or inability to leave work to be able to attend these appointments. So that also provides a really unique opportunity. From a community and health system level, there are some exciting ideas around pairing with pediatrics care. We know that many parents will bring their children in for all their well visits, yet not access care themselves. So these ideas of two-generation clinics may also be really exciting to help try to bridge the gap in care.
Yeah, so that leads to my next question, which is, which type of clinicians do you envision providing these services, or is there a variety?
I think one of the things that's been really challenging has been the idea that who really owns postpartum care. Obstetricians provide most of the care at the 6-week and early postpartum period. One of the critical gaps has been this transition from obstetrics care, where the care has been provided during pregnancy and that initial 6-week period, to primary care for ongoing continuity. We also know in individuals who have high cardiovascular risk or who've had a cardiovascular complication during pregnancy, cardiologists may also be required during this postpartum period. Thinking about clinicians broadly, including allied health professionals as well as community healthcare workers, may also help improve that ability to get access for patients and improve cardiovascular health.
Can you discuss some knowledge gaps or future directions regarding counseling about cardiovascular health?
I think one of the biggest challenges that continues to persist is not what is needed, because we know what defines optimal cardiovascular health. We know what optimal diet and what the goals for physical activity should be. But how do we implement these and how do we tailor these to each individual? Particularly because different people may require different approaches for achieving and maintaining cardiovascular health. Second, I think one of the critical things in the maternal health crisis, and broadly when we think about health disparities, are adverse social determinants of health that create barriers not just for access to healthcare, but also for optimizing and maintaining cardiovascular health. So, really thinking more broadly, as we spoke about on a health system and policy level, of what changes are needed. Our healthcare system is very fragmented, and we often know that patients are receiving care from different types of clinicians, different subspecialists. But how do we consolidate this and optimize this so that people can get the right care at the right time without having barriers to receiving this high quality of care, particularly in the postpartum period that we highlighted is a very critical period for complications.
Before closing, is there anything else that you'd like to mention that we haven't previously discussed?
We focused a lot on the birthing individual themselves when we think about cardiovascular health, but there is also emerging data that cardiovascular health during pregnancy can actually influence cardiovascular health for the offspring. So there are associations between optimal cardiovascular health during pregnancy in the pregnant person and pregnancy outcomes. So having a lower risk of hypertensive disorders of pregnancy or gestational diabetes with better cardiovascular health coming into pregnancy, but also for the children. And so that really sets up a paradigm to think across generations, where intervening in the postpartum period perhaps as a way to improve the next pregnancy's outcome and that and future children as well, but also thinking about interventions that begin in pregnancy or even before pregnancy as a way to optimize health.
Thank you so much for sharing your thoughts with us about this interesting and important topic. That was Dr. Sadiya Khan from Northwestern University Feinberg School of Medicine, and I'm Dr. Kristin Walter. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.